What I wanted to talk about just quickly is, Brian talked about the principles, and he's using these two acronyms, PIL and CROCS, to highlight those principles. The goal in, especially when you're doing a class like this, when people haven't done the concept before, and many people have not, is to make sure that you get the principles, because the principles are far more important than, in some senses, than the techniques. So the rule that I say is, I use this rule called the 80-10-10 rule. That 80% of the success of the technique is in the setup of the technique. The setup of the technique is the photograph of the technique. When you see in the textbook, this is how it looks. When we're doing a lateral glide and the hands are in such a position, etc., patient, therapist position. That's how I want you to think about it. Make sure that the patient position is good, your position, your contact is good, your arm position is good. We could take a photograph of you and we could publish that picture and say, that's the technique. Right? The next 10 is perform the glide. And remember what Brian's been talking about. And even as teachers, we relearn this and we get this point more clear each time, is being gentle. So perform the glide as gentle as possible. And some people would say as strong as is necessary. And then the last 10 is do it. Pain-free, end range, over pressure. Now, in that context, the thing of communication is important. So a lot of people just start doing techniques on each other, practicing. Speak to each other. Okay? Talk them through it. Do you feel any discomfort? I want you to feel no discomfort. Go ahead, move slowly, and etc. Okay, so...
And criticize them. Criticize each other, don't you?
Yes. Yes, the person who's receiving the technique, give feedback. This is your opportunity to learn as much as possible in a short space of time. So I just wanted to highlight a couple of those things. Okay.
Wonderful. Now look.
Shokran.
Yep.
Okay.
Okay.
Oh, here we go.
Now,
thanks.
Just quickly, has anyone here got tennis elbow? Yeah. Anyone got tennis elbow? You know? No. No. All right. Anyone got an elbow problem? No? No? All right. You have? Oh, wonderful. How long? How long? 5 years ago. Oh. Sit down. All right, look. I've got 5 minutes. Can I just talk about shoulders? Because we've got a dreadful shoulder here. But I want to go through a sequence I use when someone comes to me with pain when they move their arm. Now, I'm not interested whether they've got a painful arc. I'm only interested if you've got pain when you move your arm. And if they have, there are 3 procedures I try, and it's quite amazing. You might think you've got a rotator cuff, and when you try one of these 3 procedures, it's nothing to do with your rotator cuff. It's coming from somewhere else. Can I just quickly go through those 3 procedures, and can I just have someone come out for a minute? Someone with a nice long neck that's visible. Just quickly, would some guy come out? Is there any guy that you can? You, come on. Yes, yes, yeah, that's you. He even knows it's himself. Right, thank you. Now, someone better hold this. You were going to hold, yeah, hold this. Right. A patient comes in, they've got pain when they move their arm. I say, how sad. Now, if the pain is here, I immediately use my knowledge, because I said you must have knowledge, and that's C5. That's C5. So C5 comes out between C4 and C5 vertebrae in the neck. So if they've got pain in the arm, the first thing I do is to go to the cervical spine, and I place the lateral border of my thumb on C4, and I use my index finger, I keep the head straight, and I push C4 across. And then I say to the patient, lift your arm. And if they have no pain, I know there's nothing wrong with their shoulder. It's the cervical spine. Now, I was in London 3 days ago, someone with a very painful arm. I did that. She had no pain. So I told her to put her own finger on her C4, pull it across, and she was to do 10 of those every day, 10, 4 or 5 times a day. And if she did that, we've fixed her. She'll come back next time and will be better. And it tells me, using clinical reasoning, that there's nothing wrong from here, it's all coming from there. And if you fiddle around with anything else, you get nowhere. Now, the other reason I do this as my first procedure, it takes me about 20 seconds to see if it's indicated. If it's indicated, that's my treatment, it's my choice of treatment. If nothing happens, 20 seconds, good. The next thing I do is to go to the glenohumeral joint. And I reposition the glenohumeral joint to see if this makes a difference. And when I reposition, it takes, do it accurately, it takes about 30 seconds. And I immediately know if it's the glenohumeral joint, because if it is, they have no pain. So here we are, I get hold of it, I'll just turn them around a bit for the cameras, sorry. There's the glenohumeral joint. I locate on the head of the humerus, just below the coracoid process. I locate and I move it at about 30 degrees to the sagittal plane and slightly down. So there's, and I fixate the scapula. If I don't fixate the scapula, this is useless. So that's on there. I'm on the humeral head. I move it back and down. Can you feel that? Now, I sustain that, and I ask him to lift his arm slowly. And as he comes up, just keep going, all the way. I go with him. Now, I have a constant pressure on that. Will you agree? Yes. It doesn't change. Up you go. I sustain it all the way up and all the way down. And that takes half a minute. If there's pain, okay, that's no good. I go to the scapula. Have we got a chair? Yeah. Just have a chair. Thank you.
3 helpers.
Yeah, 3 helpers. It's very heavy. Under his behind. Oh, good boy. He knows how to sit. The third thing I do is to go to the scapula. Now, I want you just to lift your shoulder up like that. Just got it up? Now, can you lift your arm? You can't. If you keep that up, you can't get your arm up. If you relax, you can. But if you do that, doesn't that make you think that we should have looked at the scapula and see if repositioning the scapula might make a difference? Because with my scapula there, I've lost function. So that makes me look at a scapula and do something for it. Now, it was easier for me because I would have patients with their clothes off and I look at scapulas and I could see something in people with bad shoulders that I couldn't see with the normal. And that was, it was slightly raised. You mightn't notice it, but it was. And if the scapula is out of position, the outer part of the scapulas come up, and when that comes up, it's rotating. And the other thing with bad shoulders, it's not only coming up and rotating, it starts to go round the chest wall. Because when it's not working properly, to get your arm up, the scapula comes round here, and people with very chronic shoulders get pain here, only because the scapula is going round, and it makes it sore. So, it's come up, it's rotated, and it's gone round the side. And something else happens. If you look at that scapula and the clavicle, the angle here is opening. And it's not where it should be. And all that positional fault that's occurring in the scapula affects the acromioclavicular joint. So this is a technique for people with shoulder problems and also the AC joint. If someone comes in and that's painful, I fix it. I don't say maybe. Oh, anyone got an AC joint? No. Damn, you're all too fit. Are you all lazy? You don't play sport or do anything. Oh, you have. Does that hurt? Sometimes. Not now. We'll go and fall over. Does that hurt? Yeah. I've got 1 minute. Come here, quick. Come on. Come on. Come on. Run. All right. Now, the scapular technique. Sorry, love. There is the spine of the scapula. Oh, you got 2 cameras. Right. Scissors. I'm going out as far as I can. That's there. I am now going to push the scapula down and bring it towards me. Okay, that's 1. That corrects the rotation. And bring it towards me. And then I'm going on the medial part of her clavicle and moving in that direction. And you have pain when you do this, right?
Oh, yeah.
Oh, yes. Just cross your fingers for me, will you? There's that correction. There's that. Now try. Now lift your arm up. What's happening?
No pain.
No pain, of course not. Look, I get so excited teaching my techniques because I get to treat people. And I get, terrible patients. I don't mean in a, you know what I mean. But to be able to do that. Now, come on, lift it up. Go again. No pain, there should be none.
Much easier, yeah.
Oh, no, much easier is not good enough. It must be completely better. And when you get it up there, my dear, you've got to give over pressure.
Okay.
Right, we stop now. Morning tea, 1:30.
You can go 5 minutes more.
Can I?
I also have
Sure, 5 minutes. Just.
Yeah.
I also have a pain on elevation. Now it's better.
Yes. So sad. Of course it's better. That's why I'm here. Right, there. And I make it look hard. So the patient is quite prepared. Have you got some money? The patient is quite prepared to pay me. So that's there, okay? Now, come on, do it. Should be all right, okay?
No pain.
No, overpressure, come on. Good girl.
No pain.
No pain, goody. Don't worry about my tummy. Let go, quick. Let go. Stop. Look, when I correct people like this, I hold my breath. People say, how long do you do it for? Just short of death. Because if I don't breathe, I die. Now, she goes up there, and I say, let go, and she stays there. So I have to stay there. So if I die, it's her fault. Right, just try again. Here.
Nice.
Oh, points to note. She said, that's better. No, I made sure there was no pain. If I let it go with that's better, your chances of fixing this are 40%, not 80. And I expect 100. Right, come on. We're going to do 10 of them. You ready?
Nice.
Now, when you go right across, stop and go back.
Okay.
Unless I collapse on your knees, and I'll be in trouble. So there we are. Go. No. There. Right? You need a strap for discipline. Right, now you can go. Very good. Oh, it's like you've got constipation. Oh.
I think I'm improved now.
Thank God.
Pain at all?
Get up for a minute. She's now like an aeroplane. She's up in the clouds.
Yeah. I
Look.
had severe pains last
Yeah, that's why I'm here. Can you see I love what I do? I'm an old codger. But, you know, people like her keep me going.
Thanks.
Of course. Morning tea. And thank you. That was the hard session. It's going to get better, all right? No, I'll clap you. Thank you. Thank you, yes. Thank you very much.